G'day team and welcome back to Overheard in the Emergency Room. I'm Dr. Cois, emergency physician, evidence nerd and your guide through the messy, fascinating world of medicine. This is Quick Hit episode number 6. If you're new here, Quick Hits are short, punchy, listener-driven episodes where I take a question from the inbox and give you the practical answer. There's no 45-minute deep dives, no 4-pillar evidence frameworks, just me, a microphone, and the answer you actually asked for. Today's question is a little different from the usual symptom or sick day question. It's the kind of question I love getting because it tells me that you're thinking like a clinician, even if you've never set foot in a hospital. The listener asked, do you have a framework that will help me read a medical paper? And the answer is yes, I do. And by the end of this 10 minutes, you will too. Here's why this matters right now. The World Economic Forum Global Risk Report has, for 2 years running, ranked misinformation and disinformation as the most severe short-term risk facing the world. That's above extreme weather and climate change, above armed conflict, above cyber attacks. That should grab your attention because the fire hose of half-truths, cherry-picked studies, and confident influences is not slowing down, and most of it is wrapped in just enough sciencey vocabulary to feel legitimate. And you do not need a PhD to push back on that. You need a framework, and that is what we're building today. Quick housekeeping before we dive in though. If you find this useful, please like, subscribe, and hit the notification bell, and head to drcois.com for the companion blog post and the free patient resources. Right, let's get into it. Misinformation is not an abstract problem. It's a clinical problem I see in my emergency department every single shift. Someone stops their cholesterol medicine because a wellness influencer told them that statins are poison. Someone delays their child's vaccines because an Instagram carousel told them that the data was hidden. Someone empties their savings on a peptide stack their favorite influencer sold them based on a single rat study. And then eventually they end up in the room with me at 2 a.m. and we're cleaning up the damage. The cost of bad information is not theoretical. It's paid in strokes, in heart attacks, in pediatric ICU admissions, and in bank accounts. But there's good news. The defense against this is not a medical degree. It's a checklist. It's the same checklist a first-year medical student is taught to apply when they read a paper for Journal Club. And it's the same checklist I still use today on a paper that I read this morning. And we're going to build that checklist by walking through a real, useful clinical question and the 3 different kinds of studies that have tried to answer it. The question, does saturated fat raise your cardiovascular risk? It's a great teaching example because there is a study at almost every level of the evidence pyramid attempting to answer it, which is exactly the situation you face in real life when you Google a health question. Before you read a single sentence of the results, you ask yourself 3 questions about the paper itself. Question 1, what kind of study is this and where is it published? Is this a perspective piece? An expert sharing an opinion? Is this an animal study where the patients are mice? Is this a petri dish study where the patients are a few cells on a slide? Is this an observational cohort where they followed real humans over years? Or is it a randomized control trial where they randomly assigned humans to one treatment or another and watched what happened? Each of these answers a different question, and each gives you a different amount of confidence. A mouse study tells you what might happen biologically. A cohort tells you what does happen in a population. A randomized trial tells you what happens when you actually intervene. Then check the journal. New England Journal of Medicine, JAMA, Lancet, BMJ, Cochrane database. These all have rigorous peer review. Smaller specialty journals can still be excellent, but a preprint server like medRxiv has almost no peer review at all. It doesn't make it wrong. It does mean you have to read it more carefully though. Question 2. Who paid for this and who wrote it? Every reputable paper has a funding statement and a conflict of interest disclosure. Read them. If the paper concludes that beef has no negative effects on cardiovascular disease risk and the funding line says supported by the beef checkoff, that should give you pause. That doesn't automatically make the paper wrong, but it raises the bar of evidence you need to accept its conclusion, especially when it conflicts with the broader literature. Then check the authors. Have they published in this field before? Are they at a credible institution? And this is a great trick. If it's a clinical trial, head to clinicaltrials.gov and look up the pre-registered protocol. Trials are supposed to declare their primary outcome before they start. If the final manuscript reports a different primary outcome and doesn't explain why, that's a red flag for something called outcome switching. and it's a telltale sign of investigator bias. Question 3. What is the PICO? PICO is the workhorse of evidence-based medicine. 4 letters. Memorize them and you will sound smarter than 90% of people commenting on this paper online. P is for population. Who was studied? Was it mice, humans, pregnant women, kids, critically ill ICU patients, or a healthy 30-year-old? I is for intervention. What did they actually do? Which drug did they use? Which dose? Which behavior change did they study? C is for comparator. What did they compare it to? Was it a placebo, standard of care, or nothing at all? O is for outcomes. What did they measure? Was it a blood test number, a heart attack rate, or death? Let's run that PICO through our 3 saturated fat papers. Paper 1, Ruth et al. 2021. The population was a small group of humans that were overfed saturated fat for a few weeks, and the researchers measured LDL particle behavior in a lab. The intervention was overfeeding with saturated fat. The comparator was overfeeding with unsaturated fat. The outcome was a measurement of how sticky the LDL particles were. It's a surrogate marker for whether they'd actually clog up an artery. This is a mechanism study. It tells you saturated fat changes the behavior of cholesterol particles in a worrying way. It does not tell you anyone had a heart attack. It points an arrow. It does not prove anything. Paper number 2, the 2024 umbrella review of cohort and trial data. Population. Here we had millions of adults across many different countries. The intervention was lower saturated fat intake, and the comparator was higher saturated fat intake. The outcome was cardiovascular disease events like actual heart attacks, strokes. This is a step up the evidence ladder. It pulls together the cohort data and tells you that across enormous populations, lower saturated fat tracks with lower cardiovascular disease events. Paper number 3, the 2020 Cochrane review by Hooper and colleagues. The population was adults across 15 randomized controlled trials totaling around 60,000 participants. The intervention was a dietary modification to reduce saturated fat intake. The comparator was usual diet, and the outcome was cardiovascular disease events. This is the tippy top of the pyramid. Cochrane reviews are a gold standard of evidence synthesis, systematic reviews, and meta-analyses. And the conclusion is that reducing saturated fat reduces the risk of cardiovascular events by about 17%. That's a robust, replicated, high-confidence finding. Now look at what just happened. 3 papers, same question, 3 completely different weights of evidence. If you only read paper 1, you might shrug and ignore it. If you only read the umbrella review, you might feel pretty convinced. And the Cochrane review gives you near certainty. Stack them up, mechanism, then epidemiology, then randomized controlled trial. And the answer to the original question becomes clear. The body of evidence converges, and that convergence is what we mean when we say a finding is evidence-based. A few quick red flags that I'm scanning for, even though I won't say it out loud. One study showed. One study is a starting point, not a conclusion. Real findings are replicable. Be deeply suspicious of any health claim that is based on a single paper, especially without important caveats. Surrogate outcomes dressed up as patient outcomes. A drug that lowers a blood test number is not the same as a drug that prevents a heart attack. Always ask, did the trial measure a number or did it measure a human getting sick? Relative risk without absolute risk. Cuts your risk in half. Sounds enormous, but half of 0.01% baseline risk is still a rounding error. Always ask, half of what? Cherry picking. If the influencer cites 3 papers and ignores the other 30 that contradict them, that is not science. That's a debate club tactic in a lab coat. Conclusions that don't match the data. Read the results section before you read the abstract. The abstract is the author's pitch. The results are the actual story. You don't need to be an expert to be a discerning consumer of medical information, but you do have to practice. So here's your homework. And this is your Tier 1 callback for this episode. The foundations of good health include the foundations of good thinking. A discerning brain is part of the longevity toolkit, right alongside diet, sleep, exercise, mental health, and a primary care doctor who knows you. This week, find one health claim that has been bouncing around your social feed. Track it back to the paper, then run 3 questions. What kind of study is it? Who paid for it? What is the PICO? Then ask yourself the most important question of all. Does this paper actually answer the question I'm interested in? You will be shocked how often the answer is no. And you'll be shocked how quickly that one habit changes the way you consume health information forever. And that's your quick hit. If you got value from this, I've got 3 quick asks for you. Number 1, what's the next quick hit you want me to answer? Drop it in the comments, send it via the website, or DM me on the socials. These episodes are entirely listener driven and the inbox is open. 2, like, subscribe, and hit the notification bell. 3, share this episode with someone in your life who keeps falling for wellness influencers, conspiracy carousels, or 2 a.m. Google rabbit holes. This is the antidote. If you want to go deeper, the companion blog post at drcois.com walks through the 3 saturated fat papers in more detail, with the links so you can pull them up yourself and apply the PICO framework as you read along. That is the best way to actually internalize this skill. And keep an eye on the feed for new episodes of Overheard Journal Club, where I take a single paper and break it down using exactly this framework, but with the volume turned all the way up to 11 for the clinicians and trainees in the audience. I'm Dr. Cois. Let's chase less bad days and more good decades together. I'll see you next time, and hopefully not in my emergency department.